Very special guest. We have the American Cancer Society's Senior Vice President for Global Health, Ambassador Sally Cowal. Sally Cowal is a former U.S. ambassador and a Foreign Services officer. She brings an incredible depth of knowledge regarding governments, nonprofits, health-related experience to her role as the health of our global health team. Her prior work experience circles the globe numerous times. She helped found the Joint United Nations Program on HIV/AIDS in Switzerland and worked as its Director for External Relations. She was also appointed by President George H.W. Bush and then Clinton as the U.S. Ambassador to the Republic of Trinidad and Tobago. Her prior State Department assignments have taken her from Mexico, United Nations, to India, Colombia, and Israel. Her full bio is in your pre-read information. I'm sure that you saw it. If I went through it all, we'd be behind schedule already. So, and she's going to introduce members of her staff who will be helping her present today. And at this point, I would like to turn the agenda over to Ambassador Sally.
Well, good morning, everybody. It's so lovely to be with you all. And I came in last night. We had a wonderful event at the home of Ray and Stephanie Lane, and I had a chance to meet a few of the board members, Kurt, Lori, and several others who were there with us last night. It was a chance to introduce what we're trying to do in the global fight against cancer to some important folks in Northern California. So that was a great privilege. And I really want to thank David particularly. It's since I first met David several months ago in Atlanta, he has been reminding me of the important work that the California Division did really in pioneering some of the global efforts of the American Cancer Society. And he said, please come to our May board meeting and let us know what your current priorities are and what really is happening in the world outside of our own borders. So I want to particularly thank David as well as the board leadership for the invitation to join you here today. As you heard from Lori's capsule of my biography, I've been around the block a few times, shall we say. The first, when I was a child, the first 25 years of my career I spent as a U.S. diplomat, and I joined the Foreign Service in 1966, and of course the real important battle of the time, or so it seemed to me, was the fight against communism, against the Soviet Union, against China, against these other countries that presented to us a different way of life and a different value system. And it seemed, as a proud American to me, very important that we be able to present our own views on the world stage and to see that what we believe in terms of human rights and freedom and dignity would survive and thrive in the world. When I got to the place in my life where I had done pretty much everything in the Foreign Service that I wanted to do, I had been an ambassador, I had served in all of these places, I thought, well, I'm 49 years old, what's the next challenge? What can I do? And as I looked around the world, you know, the world had changed so much. The Soviet Union didn't exist anymore. The Berlin Wall had fallen. I had spent most of my life in the developing world. And so really, as I looked at the problems from the perspective of 1991 versus the perspective of 1996, I thought, well, gosh, our real enemies are not countries. Our real enemies are poverty and underdevelopment and poor health. And to me, from what I had seen, health seemed to be the most important starting point for all the rest of what follows in human development. And it was just at the time when we were beginning to hear about the devastating effect that AIDS was having, particularly in sub-Saharan Africa, but also in the Caribbean where I was living at the time and in many other places around the world as well. And so that's when I accepted an invitation to become the deputy director of a new UN program on HIV and AIDS called UNAIDS. Which has certainly led the way since 1995 for a real change in how we approach health issues in the developing world. And so it's part of that experience that I bring with me to cancer and to what I now, again, shifting fast forward to 20 years later, and what we see, and this is what I'll get into a little bit in my more formal presentation, but I think we're really now beginning to see in virtually all countries around the world a shift from the most important health burden in those societies being communicable diseases and maternal and child health to being these chronic diseases, cancer very high on the list. So in virtually every country in the world, it's now cancer and other non-communicable diseases which are creating the greatest health burden. So again, I've sort of followed my passion. And I must say, for me, it's groups like this which are so unique and so motivating. And you know, there are 1,000 reasons why I joined, tens of thousands of reasons, maybe millions of reasons why I joined, accepted the invitation to join ACS. And that was after meeting Cynthia LeBlanc in Montreal when she was chairing the ACS board. And I came up to the World Cancer Congress representing an organization called Population Services International, working in 65 countries around the world on HIV/AIDS and other communicable diseases. And I thought, I need to know more about what I'm hearing about. I need to know more about what's happening with cancer in the world. And I came to Montreal, and that's where I met Anne, and that's where I met Cynthia. And little did I know that I would be coming to join them as a member of the team. But as I said, the reason I did it was really for people like you, because I've spent my whole career obviously in international affairs, but working for organizations which had very little to virtually no U.S. presence at all. And so for me, what's so tremendously powerful about the ACS model is the grassroots networks of people who, as volunteers, come together around a cause and do a tremendous job at fighting it. So to bring all of you to the global health space, to inform you and through you, all of your constituents and your communities around California and around the nation about what's happening in the world outside of our shores is really incredibly important. So I know as volunteer leaders in the California division, you've made a tremendous and an important and a worthwhile commitment to finishing the fight against cancer. And in California, you know, we all know and respect California for the work that has been done to have clean indoor air acts, have environmental regulations which are stronger than those, I think, in all of the other 49 states. I also know that California has more current ACS grants in effect than any other state. So there's a lot of important research and development going on out here. And you are really the leaders in this fight against cancer. And I know that you know that fight from the perspective of your local or state, and many of you have been on the national board over time or are still on the national board. But the message that I want to deliver to you today is that you're really part of a global movement as well as just a national movement. And it's a global movement that I have seen in my 7 months with ACS. I've been everywhere from Melbourne, Australia to Durban, South Africa, with a little bit of Brazil and Costa Rica and London and many other countries, just for the flavor and to exacerbate the jet lag sort of thrown into the mix. And I've been able to meet an incredible array of people, and I know that we're all part of the same thing. As every one of you in this room is as part of that battle as the mother I met, the Kenyan mother I met in South Africa, who had lost her son to Burkitt's lymphoma for lack of $500 to pay for the chemotherapy treatments that would have helped her son to live. And I know that in the United States now, because of the advances we've made in treating pediatric cancers, 90% of the children in the United States survive, and 90% of the children who have the same diseases in Africa die. So it's an incredible equity gap. But you're part of that movement every bit as much as the mother who lost her son in Kenya. or as much as the man 2 weeks ago who walked his first relay in Bakersville, California, or the breast cancer survivor whom I met a few months ago in Brazil, who participated in the first ever lobby day in Brasilia, where they organized 150 breast cancer survivors who came to Brasilia for the day, and they, for the first time on a health issue, they met with every one of the parliamentarians who represent the various districts of the parliament in Brazil. And they did that with help from ACS CAN, from some grant money given to us, by being invited to participate in the lobby day that we do in Washington, D.C. every year, where we go out and buttonhole members of Congress and we tell them that we care about cancer and we vote. So they took that example to Brazil, and they had an incredible success with it. So we are all part of something which is called cancer, and of course the cancer cell itself is a universal thing. It divides in our bodies in ways that we don't quite know how to control it anywhere. So it's an important topic, and I know that some of you have participated in the past in ACS universities. That's something that we are very interested in bringing back. We're very interested, and I talked to some of you about this even months ago in Atlanta, and I said that I was very surprised, coming new to the American Cancer Society, that we had in fact stopped doing this program, and that if many of you are associated with universities here in California and elsewhere, and I think we all know that no university would voluntarily sort of give up its alumni network. You know, nobody divorces their alumni, but we seem to have done that, and we want to use our alumni from ACS University to really build it over again and to really do ACS University 2.0. And we want your input, and we want your advice, and we want your talent to help us in that. And I think the way that we can reshape this is certainly by taking advantage of the new techniques we have in communication. In fact, everything can sort of be done online. We can do e-learning. We can transmit many things. We can also use the people whom we have already trained to do trainings in their regions without always bringing everybody to the United States. But I think there's no capacity building has to be an important part of our program, and I think ACS University was an unqualified success and should be continued. So, that's one of the things we're going to do, and Anne is going to talk more about it when we get to her part of the presentation. But I'm sure that for all that we do understand this work, we also probably, as most of us as fundraisers, as people who are very involved in our own communities, you may get questions, and you may have those questions yourselves about why would we be involved in cancer control outside the United States? You know, why would we fight cancer throughout the world when we have so much work left to do in the United States? We all know that we have disparities in the United States as well, in terms of whether you're rich or poor, or whether you're urban or rural, or whether you're black or white, or whether you're an indigenous member of a tribe. We know that there are still access issues in the United States. So I understand that those are questions that can be legitimately discussed and should be. But I also think that there are ways that our communities and people of California benefit from the work that we do globally. And these are great questions, and as I talk through the global cancer burden and the impact, both in lives, in communities, in nations, and in economies, I hope I'll be able to convince you that ACS really should be and needs to be and will be and can be a leader in global cancer control. Because really we talk a lot about finishing the fight against cancer. I've heard John Seffron say many times, this will be cancer's last century. And yet to do this, to create a world really with less cancer and more birthdays, I think we need to fight together as one world. There's not a business in the United States that doesn't understand that, or not a big business in the United States that doesn't understand it's global interdependence that isn't looking for both manufacturing and sales outside of its own area. And so I think that we know as business people, and we know as medical doctors, and we know as volunteers and community activists that it's impossible, whether it's in our neighborhoods or in our world, to simply make ourselves and our own little core safe and let the rest of it go to hell around us. It just doesn't work that way. We don't exist, or we can't exist, I think, in a sustainable and long-lived way as a little island of tranquility in a turbulent sea. We need to be working together as one world. And I should also say to you, as we were reminded of by Greg Bontrager, the president of ACS, who came out for the event at the Lanes last night, that we're already part of the global cancer fight, and we might as well just take effective leadership in that fight, because since 1913, when this great organization was founded, several of its mandates speak to already talking about the global space and the need for working together internationally. And I can also tell you as a practical matter that we have a website. I'm sure you're all familiar with it, and we'll talk a little bit about our global website, but just our ACS Cancer website. And it gets, I believe in the last 6 months, I just checked this a few days ago, we had 33 million hits, I believe, in 6 months on that website, and 60% of them were from domain names outside the United States. So if you have cancer and you have internet connectivity, and that's more and more and more true in the world. I mean, people may not have a landline telephone, but they probably have a cell phone, and on their cell phone they probably can get connected somehow to the internet. And they're on to that website. So we are really already global players. But let's walk through a few of the cases for why we need to do something about cancer in the world. And I think the world is still, and I hope you can all see this, they're largely ignorant of the coming tsunami of cancer and other non-communicable diseases. The one that caused me to follow my passion from communicable diseases into non-communicable diseases is really exactly on this slide, where you see that annual deaths in the world now, and this is through some remarkable achievements. This is the good news and the bad news slide, because with these achievements, we've cut malaria deaths in half in the last 5 years or so. There's been a president's program, the President's Malaria Initiative, started by George W. Bush, continued by the Obama administration. They've joined the Global Fund on Malaria, Tuberculosis, and HIV and AIDS. And by working on education, communication, and more than anything else, getting mosquito nets out to communities in need, covering children's beds with mosquito nets, the global burden of malaria has been reduced from over 1 million deaths a year to 660,000 deaths a year, and it's going down all the time. So that's been pretty successful. I talked a little bit about having worked in AIDS in the past, and certainly 25 years ago, we just saw the numbers in AIDS go up and up and up, to the point where in some places in sub-Saharan Africa, especially southeastern Africa, places like Zimbabwe and Zambia and South Africa, up to 30% of the adult population was infected with HIV and AIDS. And there were no treatments, and there was no vaccine, and it didn't look like very much could be done. But again, there have been some wonderful breakthroughs, and there's been a wonderful commitment by the international community to really pour millions and billions of dollars into getting the effective treatments that now do exist, the protease inhibitors and all of the medications, which I'm not going to speak to because there are too many MDs in this room, but in my time at UNAIDS, I learned how to pronounce protease inhibitors, so I assume you'll think I know what I'm talking about. But what I do know is from a public policy perspective, we've seen the number of deaths from HIV and AIDS go down to 1.8 million. When you would say only 1.8 million, that's still a lot of people, but indeed that's a reduction of just a few years ago from 5 million to 1.8 million. So it's been really a dramatic drop. But at the same time as these good things are happening, of course, and partly because of increasing populations and people living longer, not dying in childbirth, not dying as a 5-year-old from a diarrheal disease, not dying as a 10-year-old from malaria, not dying as a 25-year-old from HIV/AIDS, we're now getting people old enough that they enter into the zone where the chronic diseases, where cancer becomes a huge burden. So that then we see from what is happening that cancer deaths are going up dramatically, and they're already, according to the International Agency for Research on Cancer, which is part of the World Health Organization, in 2012 there were over 8 million deaths in the world from cancer, and by 2030 that's projected to go up to 13 million deaths. So this is in such contrast with what, through your good work, we've seen happening in the United States. At the same time as this line goes up in the world, in the United States, and I say it is due to some good scientific discoveries, it's due to the advocacy of organizations like this one, that fewer people smoke, but we are seeing tremendous progress against cancer in this country. That 1.3 million lives have been saved since the mortality rates began to drop about 20 years ago. So what we see then is an increasing gap between very good progress, not self-satisfied progress, but good progress in the United States, and what's happening in the rest of the world. And of these deaths, 8 million now projected to grow to 13 million over the next 20 years, more than 60% of these deaths are in Asia, Africa, and Latin America, Central and South America. So it's 60% of the cases, and it's about 70% of the world's cancer deaths. And of course, the reason why it's proportionately even more deaths is because there is very little early detection and there is very little treatment in the world. So the cancer experience then in low-income countries is very, very different. I mean, first of all, statistically, it's different, and then it's different as a person who's experiencing cancer. Because most of these patients in the low and middle income countries are so delayed in diagnosis that 80% of them are in advanced stages of cancer, stage 3 or stage 4, by the time they get to any kind of cancer care. Many, in fact, die without ever having been seen by a physician at all. Or they're misdiagnosed by a physician and treated for totally the wrong thing. And to add additional burdens to this fairly gloomy picture is that most patients don't even have pain relief from the disease. And Shayoun, who's come with me today, is going to talk a little bit more later on this morning about our program of Treat the Pain, which is bringing some real relief in more senses than one, relief for this terrific burden of dying a death which is filled with pain and totally lacking in dignity. So that only about 12% of people in low-income countries who are dying of cancer have any access to opioids, despite the fact that morphine is considered an essential medicine by the World Health Organization, and in fact costs only pennies a day. So, no, it's again the good news story, the bad news story. Half of all the cancer survivors in the world, and there are about 28 million of us now, live in the United States, despite the fact that we have 5% of the world's population and 11% of the cancer incidence. So I really do believe that the American Cancer Society deserves much of the credit for that. And, I think we can and we must do better worldwide, because the people whose pictures you don't see here, but whose global cancer burden we do see here, are simply not benefiting from the progress that we've made in recent years, the progress that you or I have access to in the United States. So it comes down to being a rights and an equity issue. And it's also an economic issue, this tsunami, just as AIDS was many years ago, when entire industries, I saw once in Zimbabwe visiting Harare, and the place in town where all the furniture makers used to make all kinds of furniture, tables and chairs and kitchen cabinets, they had all stopped making furniture, and they started all making coffins, because it was actually, the best way to get a return on your investment was you make coffins. Everybody was dying. So, whole industries are skewed when a disease burden grows so dramatically. And we know from our experience in the United States that the cost of the cancer burden is damaging economies even of the richest countries, and it's way beyond the reach of these developing countries. To say nothing of the fact that the disease itself and the number of patients who need to be treated is placing a really impossible strain on healthcare systems. And I'm hoping that many of you will enter into this discussion, because I know many of you have experience in cancer and have experience in seeing health systems and how burdened they are in many places around the world. But we've got this tsunami coming. You realize in most places patients are not now being treated for these chronic diseases. As they begin to move into the healthcare systems and want and demand treatment for cancer, for heart disease, for diabetes, for lung diseases, the healthcare systems are going to be truly overwhelmed. And we know that this total economic burden, the cost of cancer in 2010, is over $1 trillion. That's for 1 year, and it's $1 trillion. And around the time of the 2011 high-level meeting at the United Nations, which I'll talk about more in a moment, there was some important economic health economists got together from Harvard University and from the World Economic Forum. And they did a study about if the projections on this chronic disease, not just cancer, but the rest of them as well, the projections out 20 or 30 years followed the track that they were on, that chronic diseases would cost the world $47 trillion in lost economic output in just the next 2 decades. So $47 trillion, that's even more than the Defense Department spent, I think. But it's a very big number. And just to help you get your head around it, $47 trillion is 75% of the global gross domestic product, the whole ball of wax. It's 75% of the global GDP in 2010, which was $63 trillion. And looked at another way, if we didn't have to, among the nearly half of the world's population, 2.5 million people who live on less than $2 a day, we could wipe that out for 50 years if we just weren't going to lose $47 trillion. So I think we've got a pretty important economic argument for why we can't be complacent as a nation, as a volunteer organization. We can't just sit here with our arms folded and say, well, gee, we've seen a 20% reduction. Because I don't think that we are sustainable as a nation, or as a business, or as a government, if we're going to have the rest of the world overwhelmed by this global tidal wave of chronic diseases. So we are looking at this, of course, very seriously, and we've had tremendous leadership from the board of ACS. I know there are several people here who are involved in the board. I've had the opportunity to meet them. One of the goals and transformation was really about the whole global program, and they put in place a program called Global 3.0, and that was to move the American Cancer Society into a space where it was taking a leadership role in the global fight against AIDS. So I think there are some important ways that we can lead, and that's what I want to spend most of the rest of the time I have this morning talking about. One is just exporting our knowledge about cancer control. And we have to do this, I think, both for the reasons I've said, the real economic reasons why it's not in our interest to let this tidal wave wash over us. But I think we also have a moral responsibility to do it, because after all, we've exported our Western lifestyle. We've exported obesity and physical inactivity and tobacco. So there are a few examples of that pretty close to home. Mexico, now a country that borders California, has the dubious distinction of just having surpassed the United States as the fattest country in the world. And 70% of Mexicans are now considered to be overweight, and 1/3 are obese. So that's pretty close to home. And country not so close to home, but where there are many, many, many immigrants in California, China. Did you know that 1/3 of the world's cigarettes are smoked by Chinese men alone? So we need to share our knowledge and then use our knowledge as power to fight back. And besides our knowledge, we also need to share our best practices. I mean, I just look around the room with me today, and what do I see? I see a road to recovery. I see a Relay for Life. I see a callback program. I see a Look Good, Feel Better. I don't see a Reach to Recovery, but I'm sure it's out there somewhere. I see a couple of things that in 7 months I haven't even learned about yet. But I know there are best practices here. There is some good reason why 50% of the cancer survivors in the United States live in this country. And it's not just good research, important as that is, and important as it is that the American Cancer Society is the second largest funder of cancer research in this country. But it's also all of these programs that connect people, that are important programs that we have developed, and some of them may no longer be absolutely as relevant as they were 50 years ago, 75 years ago in the United States, but let me tell you, they're still relevant in the places in the world where we work. So for instance, just this week, one of our staff members, Christy McComb, is in Brazil, and she's discussing with the Brazilians and with a very good donor, the Carolina Herrera Fashion House, extending Reach to Recovery to all of Latin America in conjunction with the Reach to Recovery international people, translating these materials, the way it works, how to train people how it works, into Spanish and Portuguese, and to launch in Brazil in the beginning of 2015, and then in other countries thereafter. And it has to be translated, of course, not just the words, but translated in a way which is culturally appropriate. But we have these tools. We know what to do. And that's what we're going to do. So our goal at ACS as a whole, we know that we need to be smart about our money, and we have to save the most lives we can, and with the greatest possible impact on the disease, have the greatest impact for the greatest number of people. So in our global health program, we're operating by exactly those same principles. We're not just saying, okay, there's going to be 13 million cases in the world. We need to work everywhere. We need to sprinkle a little fairy dust everywhere in the world. What we have decided is that we need to be very strategic about what we do. We need to be strategic both in the countries that we work in, and we need to be strategic about what we're going to help those countries do. So let me talk a little bit about that and how we are really focusing on sort of the best buys and measurable results in countries. And we're picking those countries at least as starting places where, first of all, the burden is very high. It's a significant burden. Secondly, where the policy environment is such that we think it's possible to make some progress. I mean, an example, for instance, of a country we thought we would work in and then backed away from just recently is Ukraine. We were ready to start a Treat the Pain program in Ukraine, and it's an important issue in Ukraine. And at the same time, heading into what they're going through right now politically at this very moment, it just would appear that it's just not a best buy. So I think we put Ukraine a little bit lower on our priority list in order to work in countries where the policy environment is good. And also, frankly, in the countries where all the good work that you and others like you around the country have done through ACS University and other things over the years, where we've got good connections. We know people. You know, I'm from Chicago. I'm in Chicago. They say we don't see so is Ann. We don't see nobody sent. So, you know, we want to be in places where somebody sent us, and where that Big Blue is a big brand. And that's many places around the country. And it's not just the big brand where, you know, 60% of the hits on our website are coming from 180 countries outside the United States, but places where our reputation precedes us. So what we're looking at initially as focus countries are several in Latin America: Argentina, Brazil, the Caribbean, Colombia, and Mexico, and several in Africa. And I think we, after a discussion with one of the guests last night, I think we need to expand the list in Africa by at least one, and you may have other suggestions also. But our initial focus in Africa is Nigeria, Uganda, Ethiopia, and Kenya. She persuaded me that we really need and should add a Francophone country to that list, simply for all kinds of cultural reasons, and I'm persuaded by that. So we have done some important tobacco work in Senegal, in Gabon. We have the ambassador from Gabon sponsored a dinner for us in Washington about 2 weeks ago to talk about cancer in Africa. So maybe it's Gabon, maybe it's Senegal, maybe it's Niger, but a Francophone country in Africa. And then we're working in India. And Ann and I are going to meet this afternoon with June, who many of you probably know, to see, you know, what still remains in China and whether we should, you know, I'm not sure you can dip your toe into China, but we'd like to take a look at that as well. And so the combination of those countries, I say, places where we're invited, places where we would be welcome, places where the policy environment is good, and also, you know, the big countries where you really do make a bang for your buck. Imagine if we could do something about these cancer statistics, and it was just in India and in China and in you know, Nigeria, and those three countries alone, and we would have been dealing with virtually half of the population of the world. So important. So it's going to take all of us with other international stakeholders. We will not, of course, do this alone, and we work through our UICC partnerships and others to work with other international and national organizations around the world. And as I said, we'll want to be looking not only at the countries we work in a focused way, but also what we can do. And we have broken it down into 4 buckets, essentially. And to me, they are all, shall we say, they're really locked together. They're really woven together like a good Persian carpet. That you can't do one, and I think Kurt and others in the public health world would back me up on this, that you need to look at it in a very holistic way. I mean, you certainly starts out there with, we got to prevent cancer. We can't treat our way out of this epidemic. I mean, we have to prevent it. And we know a lot of good things about how to prevent cancer. And I think it starts in a public policy environment. It also starts with a behavior change framework. There are things individuals can do to reduce their risk, and there are things that, as you all know, we can do about air quality, and we can do about tobacco regulations that are an assist to cancer prevention. So the first thing that we want to do is to reduce exposure to the cancer risk factors, and that's of course alcohol and nutrition and obesity and physical inactivity, and especially tobacco. And in tobacco, we need to counter industry's marketing. I can't tell you that how much the tobacco companies are looking, for instance, at Chinese women, because while 50% of those Chinese men smoke, and they smoke a third of all the cigarettes in the world, only 10% of Chinese women smoke. So, boy, that's kind of, I don't know if anybody here works for an advertising agency, but I can bet that that would be a very good audience that you would target. The other one who are really being targeted are African women. And we've done some recent research in Africa, which currently has the lowest smoking levels and is on a trajectory to have very high smoking levels. And that's happening because disposable income is going up. So as people have more income, they buy more products. And one of the products that you buy are the products that get promoted to you. And they're promoting tobacco to African women the same way they promoted it to American women of my generation in the 1970s, which is that this was cool, this was liberated, this was you could walk down the street with a cigarette, this was modern, this was keeping you slim and trim and skinny and sexy. And all of that is music to the ears of African women who are emerging from or emerging through their own liberation fights. So we need to counter the industry's marketing, we need to increase taxes, and we need to stigmatize smoking in places around the world, and I think that will do a tremendous amount to reduce exposure to probably the most important cancer risk factor, which is use of tobacco. The second thing, and it's also an incredibly good best buy, is vaccination against infectious causes of cancer. And that is HPV and hepatitis B. Now again, back to my days in the AIDS world, as you know, we still don't have a vaccine for HIV, but in all the years that I was working there, people would go around saying, if only we had a vaccine, if we just had a vaccine. And literally through the Gates Foundation and other organizations, billions of dollars are being poured into vaccine research for HIV. And that's wonderful and it's good, and yes, it will be, if and when it's ever a successful vaccine is developed, it will be an important armament in the toolkit against HIV. But guess what? We got a vaccine against HPV. In fact, we have two vaccines. GSK produces one, Merck produces the other. Through the Gavi program, which is a global alliance on vaccines for Gavi eligible countries, these are being made available to countries at extremely low cost. While it's a pretty expensive vaccine here, the companies have agreed to provide it to Gavi at a low cost, and a cost which is subsidized by Gavi. And I think, Anne, are you going to talk a little bit more about this? So I'll get off of that. But we've had a vaccine for 6 years, and yet we don't have national vaccination programs which are successful in very many countries. To say the obvious, we don't even have a vaccine program in this country which is very successful. We have about, according to the president's report issued the other day, about 30% of eligible young women, young boys and girls in the United States are being vaccinated against HPV. Come on. This is an anti-cancer vaccine. I was in Brazil the other day when they were rolling it out nationally, and knowing what I know about the success of public health in Brazil, they're doing it through school-based programs, and I think they'll probably do a pretty good job. The Australians have a 95% vaccination rate, for example, with HPV vaccine. But again, this is something where in places where it's possible, we're going to do everything we can to promote HPV vaccine. And that will make a huge difference. 1/3 of cancers in Africa have an infectious cause, which is far higher than we experience in the United States. So this is really a no-brainer, right? This is not either a policy change or a behavior change, really. It's a go get vaccinated changed. We've done very well with the childhood vaccinations. You know, most kids in the world these days are vaccinated. We have actually wiped out smallpox. Again, the good news, through having a vaccine. We now have a vaccine for HPV. Let's see that we can do something about it. The third area of prevention is really the one that sort of straddles the bridge between prevention and treatment, and that's screening. There's very little screening taking place. We want to particularly start with cervical cancer and breast cancer. Cervical cancer, there have been incredible breakthroughs. Again, I'm not going to steal Ann's thunder, but I think through we're getting off of the pap smear, which has been difficult to do because of poor pathology in many places around the world. It's also very expensive. It also requires like a 2-week waiting period, so you get a woman there and then you do a pap smear, and then let's even assume that the pap smear is correctly read. You have to ask her to come back in 2 weeks, and you lose many people to follow up because they're in a setting where maybe they're 5-mile walk away from that health clinic where they had the pap smear. And the day that they're supposed to go back, you know, the corn has to be picked, so they don't get back. The new technique of screening sounds so simple that you would imagine it couldn't be really impactful, and yet it is. And all you need is a bright light and some vinegar and cryotherapy, which is essentially, you know, carbon dioxide freezing things off, same kind of thing you use in a soft drink machine to have some carbonation. And if you can examine a woman's cervix under a bright light, having put vinegar on it, precancerous lesions will show up very easily. They'll show up as big white spots. And right there, while she's still got her feet in the stirrups, you can apply a cryotherapy wand and you can remove those precancerous lesions. And the results are that, you know, 80% of those women will not proceed to have cervical cancer. So it's called VIA, and the WHO is coming out with guidelines that endorse it as the approach for cervical cancer screening in low-income settings. And what we need to do about that is also to incorporate that method of screening into more primary health facilities. So if a woman comes in to an antenatal clinic, let's say, you know, she's being monitored for her pregnancy. Why wouldn't you take an extra 2 minutes and look at her cervix and do something about those lesions if you find them? There's a lot of work being done. We've seen these rates go down for HIV. So that's because there's a lot of attention being paid to HIV, particularly in Africa, but in Asia as well. So if you're doing counseling and voluntary counseling and testing for HIV in a high AIDS incidence country, why wouldn't you also offer that woman screening with VIA? Because we know that women who are HIV positive are 10 times more likely to have cervical cancer. So we're already seeing these people in some settings. Can't we make that more comprehensive without a lot of additional cost through a lot of task sharing and task shifting? This doesn't have to be something that a physician does. This can be something that the equivalent of a nurse or a nurse practitioner does. So we're looking at getting screening out. A little bit more difficult with breast cancer, but I think there have been some recent studies showing that clinical breast exams, again, performed by a trained provider, can be, and I'm not going to stand up against mammography, which is, again, a gold standard and a wonderful treatment. It's just not happening everywhere in the world. So my philosophy on all these things is, you know, prevent the preventable, do what you can. And it may not be everything, but I think we shouldn't let the perfect be the enemy of the good. So if we can do cervical cancer screening with VIA, and we can do clinical breast exams, and we can do them with women who are already coming into a facility of some kind for some purpose, we will make a tremendous impact on cancer in the developing world, particularly for women. And then the fourth thing that I think we need to do is work in sort of a whole approach to promote healthy behaviors, good physical activity, you know, healthy eating. I don't know, should I stop there and say, does anybody have any questions? Because I feel like I've been talking for a long time, and I've got 3 other things I want to say, but if there are, I probably have 33 other things I want to say, but I want to stop and give you a chance. Is there anything else in the prevention area that you think we should do? Are there any questions about the statistics I've presented that anyone would like to present something else, challenge, talk about, have me talk about? Mac. Dr. Roach, sorry.
Presentation. Mac works good. I was curious about the Middle Eastern part of the world. You know, I have a friend who's from Afghanistan. I asked her, what happens in Afghanistan when people are diagnosed with cancer? She said they die.
Yeah.
So I understand that you put it in context. You said we need to be in places where people are receptive and we can get stuff done, but I mean, we also have a footprint.
Right.
With a big hole in the ground over there somewhere. And I think that in terms of building goodwill, there's some other places, in addition to Africa, that's out there,
Right.
in Asia. You know, so I'm curious about your thoughts about a place like Afghanistan.
Yeah. I mean, my thought is that your thought is a correct one. I think at the moment we are a team of about 14 people. If we get to the point in Afghanistan where we could piggyback on some of the efforts that have gone on with the U.S. military and USAID, I think it's a good thought. We are doing the Tobacco and Health Conference next year will be in Abu Dhabi, and we're starting a Relay for Life in Abu Dhabi, so we're beginning to learn a little bit more about the Middle East. We have had traditional partnerships in Jordan, I believe. But you know, I guess the Middle East falls into that area of the world and has for all the years back since I lived in Israel many years ago, and maybe since time immemorial. But it falls into a category of so many issues, you know, just so much going on in a political sense that harder to carve out, you know, the focus on healthcare. But we certainly know in all of the Middle East, smoking is very high. The incidence of smoking is extremely high. I mean, one of the things that we're going to do this time is the Tobacco Atlas in Arabic. So we'll begin to get, as part of the knowledge thing, some materials out there. And I think everything that we do and everything which is on our website is certainly available globally. It's just a matter of deciding which are the most important countries to have programs where we actually have boots on the ground, or at least, you know, sandals on the ground, something on the ground, working through with ourselves and through some affiliated organizations. So, good point. We take it under advisement. We'll be looking at areas in the Middle East.
I just have a question about the statistics on cancer deaths. Have we looked at childhood cancers in any of the countries that we are going to be focusing on? What comes to mind, again, from a marketing perspective and revenue generation? You know, are those of us that are up at 2 in the morning, you know, that are looking at, you know, the children in need, or they get the emails from St. Jude every other day. You know, is that something that we have considered in telling our story and getting people engaged?
The answer to the question is yes, yes, and yes. And there is, you know, if we're looking to close equity gaps, as I've mentioned, one of the hugest ones is the fact that 90% of the children survive here, 90% of the children die there. We have, as I go through this, it's more into the treatment area in terms of children, because there's, you know, again, I defer to the medical personnel in the room, but I think it's harder to have a really early diagnosis. I mean, you try to diagnose it as early as you can, but regular screening is maybe a little bit more difficult. But we certainly know that for lymphoma and leukemia, there are some very good drugs out there. And my understanding, and as we build out our staff, we're adding people to our treatment area, and we're adding somebody specifically on pediatric cancers. So it is something that we will be looking at, is trying to get the chemotherapy regimens out there in the countries where they're most needed. I mean, there's a whole Again, there's a tie-in with malaria to some kinds of children's cancers. So there's a whole belt where malaria is high, these cancers are high. I think we can begin to do some work, and I agree with you. It's both an important issue because we can make a difference, and it's an important issue because I think it's we can make a difference in terms of getting the world's attention. I mean, around children. So, good question. Sorry, Allison. I'm looking at the.
Just a simple question. You had said before, looking at the notes here, that we've got 30% of the children are now being vaccinated for HPV.
In the United States.
In the U.S.
Yeah.
Is that both boys and girls, or is that just girls? And how are we doing with boys? We know we're talking about it, but are we there yet?
Yeah. You know, I don't have any information. I believe that 30% is just girls. Is that right, Lori?
I believe that's right. I'm not an
Right.
expert, but I haven't heard any data on
Right.
boys.
And I know we're encouraging boys now also, or the mothers of boys, to vaccinate them, but I would presume, in fact, I think I do know that. The 30% is girls, and boys is much lower than that. Okay, are we ready to move? Should we look at what to do in treatment and saving lives? So I said we won't, treat our way out of this cancer coming, but we won't prevent our way out of it either, because the two really do have to work hand in hand. Back in the days when there were no AIDS treatment available, nobody wanted to have an HIV test. I mean, why would you want to have a test for HIV, learn you were HIV positive, and then that was it, right? So we promote testing for HIV because we have treatments for HIV. So people want to know, and they want to know early. So it has become the case, and many people have told me this, and I have heard it myself, that the most dreaded diagnosis in Africa now that you can hear is cancer. It's no longer HIV, it's cancer, because we know what to do about HIV, and we don't know what to do about cancer. So I think we need to have treatments out there, and that needs to be the full panoply in some way or another, starting with the ones that are easier to do in low resource settings. But there are some things we can do about chemotherapy, certainly for these children's cancers. And actually only 5% of those who need chemotherapy in sub-Saharan Africa receive it. So, maybe we can't get to 100%, but maybe we can double that. Maybe we can quadruple that. There's one machine, and it's an old machine. And so it takes 12 hours to get a treatment on that machine. And so do the math. Even if the machine worked perfectly, which I can assure you it doesn't, and if you needed a 12-hour treatment, how many people would be able to be treated in the course of a year? And when you do that math, you realize that most people die waiting for their treatment. I mean, they will not be alive when their scheduled appointment comes up. So, we have a country like Ethiopia where we're beginning to work. It has a population of 84 million people. That's about a quarter of the population in the United States. They have in only one cancer referral hospital in the country, and it has 18 beds. So, there are gaps to be filled here. And I think we can begin to chip away and see where these gaps are and how we can fill them. So that's what we plan to do to, follow the American Cancer Society of helping you stay well and get well. So stay well, prevention, get well, treatment. We're also talking to some MD Anderson and Harvard and some others about training of surgeons in countries. And again, maybe all kinds of surgery are not possible, but some kinds of surgery are possible and can be done. I saw a wonderful cancer hospital in Brazil a month ago where all the doctors are Brazilian. They're working with MD Anderson. They've all been trained either by MD Anderson people coming there or the physicians going to Texas to be trained. They're paid more than a living wage, so they want to stay there, they want to work there. The answer to surgery is not just, a few surgeons, great as they are, flying in for a week and doing some surgeries and going back home. I mean, what if you show up the next week? I mean, the answer has to be to train local surgeons to be able to do cancer surgery. So I think we need to be working on all of these things. And I'm thrilled that there are radiologists and oncologists and surgeons among us who want to work with us on training and getting some of these life-saving methods out there. The third area that we want to work on and need to work on, and you're going to spend a lot of time on this, I know this afternoon, is the whole quality of life issue. And that, is both the pain relief issue and sort of helping people survive and thrive in other ways through their cancer treatment experience. And I already talked about what we're doing with Reach to Recovery, but I think there are many of these programs which help people improve the quality of their life that we can make available to our colleagues and friends around the world. Shaun will talk more about our pain programs, but just another statistic there is that 85% of the population of the world that lives in low and middle income countries consumes just 7% of the opioids in the world. So 85% of the people, 7% of the opioids, and what does that translate into? One big cry, And the final area that we think is very important, and this is certainly where our colleagues in ACS can play an incredibly important role, is the advocacy area. And advocacy is not just doing advocacy with governments, although I think that's extremely important because one of the good things that's happened in the world since I started being in the world is that most countries are now democracies. At least, and they may not be a democracy quite the way this is a democracy, but in most countries around the world, public opinion is important. And so this idea that I have cancer and I vote is a powerful message in many places around the world. You won't stay in office as a prime minister or a president if people are dissatisfied with the amount of money, care, and attention that their government is putting into healthcare and in helping them and their families fight cancer. So I think people around the world are asking for our advocacy training. And so ACS CAN is really expanding its mission to support our global health efforts, both by training people outside the United States and also by getting our wonderful Washington team and our volunteers around the country. I went to Dallas a couple of weeks ago for the state lead ambassador meeting of the Cancer Advocates Network. So by getting these people to also have for our legislators and our president in Washington a global ask. So we want this network to say we not only want what we want in the United States, but we want the United States to not to take money from our HHS allocations that would go to fund cancer research, but to shift what the United States is doing in terms of funding global health from malaria, HIV, tuberculosis, communicable diseases, toward where the real burden of disease is, which is on non-communicable diseases. So currently our government spends $9 billion on global health. This comes out of the State Department budget. This does not come out of the HHS budget, but it's about $9 billion. We're actually, I'm proud to say, the biggest global health funder in the world. And really, if you put us together, the US government, with, for instance, the Gates Foundation, which also spends an incredible amount of money on funding global health, it's a very significant force in the world. But of that $9 billion of US government money, less than 400,000 is going toward any chronic diseases. So you have, 65% of the burden of disease and less than 1% of the funding. So that's out of whack, and that's something that advocacy can, I believe, do something about. So ACS CAN is really staffing up its grassroots network to recruit new advocates with a specific focus on global health. We've just commissioned a study about what if Americans care about their trade agreements, and whether their trade agreements should have provisions that countries don't have to give free access to tobacco companies, even though they have a trade agreement with us. And there's a big fight going on now, as you probably know, with the Trans-Pacific Partnership, the TTP, that the Obama administration is negotiating with, I think it's 15 countries in Asia. And so the interesting findings from the public opinion poll were that Americans care intensely about this. You know, they don't want us to be polluting the world. They really don't. If you remember back to NAFTA, which is something that I was in charge of negotiating in my foreign service career, and that's the first time that into a trade agreement came environmental and labor standards. Because before that, trade agreements had just been about, I'm going to sell you steel and you're going to sell me, you know, cotton, and we're going to do this and we're going to do this. Time of NAFTA, the labor unions and the environmental movements got very activated, and they said, you know, we shouldn't really be just importing all this stuff from, and it's being produced in sweatshops and it's being produced where environmental pollution, it costs us a lot to produce things in California because we have to conform to very high environmental standards. So we shouldn't import things from China, which has no environmental standards. So those first came into trade agreements then and were important parts of it. When we did this polling to say, you know, how important is environment, how important are labor standards, and how important is public health, the one that they cared most about was public health. So believe me, we're using these findings to intervene in trade agreements and into funding. So, you know, we're going to build this grassroots army. We're going to build it through ACSU. We're going to build it through having cancer advocates trained, like I talked about our program in Brazil. And we would like volunteers who know something about this to help us go out and train volunteers in other countries. We're also going to be doing a lot more with Relay for Life, and I'll talk about that because it's as important to be able to give countries a sustainable funding base as anything else that we might teach them how to do. And Relay for Life is certainly one of the keys for that. So there's our Relay for Life slide. We're in 23 countries now. We're expanding to 26 countries. That includes some developing countries. One of them, which is starting up this year, is in Kenya. We've already trained. It's not just licensing the brand, the Relay for Life brand, which we do license, but it's also to license the brand is to buy into the whole package, to buy into knowing how to put together a relay event, what makes it successful. How do you even, control the funds? I mean, what do you have to be aware of when you're doing it? So we expected, I think it was like 35 people to come out for the training in Kenya, and you were there, Ann. How many people came? Close to 100. So 3 times the number of people as we expected came. And they're having their first relay in June, next month. And their goal is to raise, I don't know what it is in shillings, but enough money to get 1,500 people on treatment. You know, that's an incredible difference. I mean, in a country that lives on $2 a day, there's not much cancer treatment going on. So 1,500 people a day, and not as a gift from anybody else, but raised from relay teams. So that's very important. And I think the second part of that relay, and that is also important to us at the global team, because we have now agreed with the powers that be in Atlanta that the funds that come into ACS because of the license fees, and of course the license fee is we're establishing at 5%. We're not there with every country yet, but the target is 5%, and that's what we're enforcing. So with countries like the UK and Australia and Canada, this is a significant source of revenue, and the board has now agreed that the revenue above expenses for putting on these programs will come to fund the global program. So that's going to be a tremendous shot in the arm for our efforts globally. And I think it's also important to our partners in other countries. They're not necessarily interested in a license fee funding our activities so much in the United States because they think we're a wealthy country and we ought to be able to fund our own. So saying to them that we're actually using these license fees in order to help low and middle income countries experience the incredible power of Relay for Life and these other things is I believe, very important. So we've come, as they would say in the Virginia Slims ad, we've come a long way, baby. And I think we should be proud of the things that we have done. And I say that of the things that were done long before I got there. We are standing on, as they say, on the shoulders of giants, but that's really true. It was through incredible efforts by Anne, John Seffrin, and the rest of the team that the United Nations held its first head of state meeting about non-communicable diseases in 2011. Now, the United Nations was founded here in San Francisco. It remains a very important organization in terms of the world's agenda. So the United Nations had only in its history held one meeting before on anything to do with health. The United Nations usually deals with threats to peace and security. Health is one of those, but it has not been considered so. So in 2001, they had a high-level meeting on HIV and AIDS. And with our advocacy, heads of state and world leaders came together to discuss non-communicable diseases in 2011, and Dr. Seffrin was one of the principal players in that high-level meeting. And they adopted a political declaration that says, that recognizes what the statistics are and what the burden on health is. And so we've been continuing to work with the United Nations and especially with the World Health Organization, which is having its World Health Assembly this week, to begin to put some real targets and goals. And the goal that they have established, targets and goals around reduction in non-communicable diseases. And the big, as they would say, the BHAG, the big, hairy, audacious goal that's out there now, is that we would reduce by 25% the premature mortality from non-communicable diseases by the year 2025. So it's 25 by 25. So that's great to say. It's a big, lofty BHAG. It's a big goal. But how do you bring it home? How do you make it happen? And so in order to make it happen, we established a program called Meet the Targets. And Meet the Targets was a program to make sure that global momentum actually translated into action on the ground. And so the program supports 10 grantees in 9 priority countries. And they were small grants of $20,000, $40,000 over a period of time to help the countries build their capacity to implement the tactics we know are successful in fighting cancer. For instance, in Brazil, the grant supports a campaign for national anti-tobacco law, and that has been very successful. They're doing, every few years, as all countries do, they do a smoking prevalence rate statistic. They do a national survey, and the national survey is being done this summer in Brazil. And when I met with the head of the National Cancer Institute there, he told me they expect the figure to come in at 13% of the population is smoking. Well, as you know, it's 18% in the United States. So just a few years ago in Brazil, many fewer years ago than we were at 50%, they were at 50%. So to have brought that down, I think, we can take justifiable pride in that. In Uganda, the grant supports efforts to develop the country's first palliative care policy. So really, I think we can say that already we are the only civil society cancer organization that's supporting country-level advocacy campaigns on non-communicable diseases. And I believe that's as it should be. We are the largest voluntary health organization in the world, and we have the expertise through 100 years of fighting cancer to lead the world on an initiative like this. Finally, I'd like to say a couple of more words to tobacco, and I already mentioned this, but through a grant with the Gates Foundation, we've engaged with 5 other partners like Tobacco Free Kids and a couple of others to prevent and reduce tobacco use in Africa. And this involves 10 countries in Africa because we know that the number of Africans who smoke could increase to 572 million by the end of this century. It's 77 million today. If we see those kinds of rises in smoking, we know what happens in lung cancer. I mean, that's as, does day follow night? Yes, it does. Does lung cancer follow increased rates of smoking? Yes, it does. So we are fighting very hard with this money in a tobacco initiative. And I think really that if we do nothing else but stem the rising tide of tobacco use in low and middle income countries, we will have done everything. So at this point, I would like to introduce an important and the newest member of my team, Seun Adibidi, and he joined us 6 weeks ago. And he joins us from the United States, but he comes originally from Nigeria, and he has an incredible personal story, and he has incredible professional credentials in the business world and investment banking. So we've combined an advocate with a person who knows how to get things done, both here and abroad. And Seun is our program manager on the pain relief program. So I would like to introduce him and ask him to say a few words and share a few slides. So thank you, Seun.